are now open to questions. So, may I invite, so shall I start? Okay, ladies first, as always. So let's start. Where have we got microphones? Lovely, thank you very much. And please forgive me, because I can't hear on one side. I really can't tell where noise is coming, so hands up would be brilliant. So yes, please.
Hi, sorry. Oh, it'll do automatically. My name's Diane, I'm a consultant, but I'm actually, I left clinical medicine actually and went into consulting, so a bit of a controversial move. But do you think the government is actually helping out enough with things like workforce solutions? I'm just going to use one example, and we've talked about virtual wards and lots of other things which, for example, physician associates could really be utilised for, but currently there's a huge barrier because they're not regulated, even though it was announced back in 2018 that they would be, and we're now in 2023 and still nothing. And they can help in all different types of areas to help relieve doctors to see the more acutely unwell or the patients that need more specialist care.
Thank you. Niall, do you want to start and then I'll come in?
I mean, there's definitely a role for physician associates in virtual wards, no doubt about that. I mean, Stella probably knows more about government issues than I do, but I think you've got to remember that, I guess there's the government, then there's NHS England, and then there's the ICSs, and then there's the local providers. And obviously that's a very complicated landscape to deliver change through. And certainly for virtual wards, the government is highly supportive of it because they think that it can make a massive difference, and the key decision makers there really bought into it. They then tell NHS England that this is a very good idea and they want to support it. NHS England then sets targets and looks at the funding, and then it sort of comes down to the local level for people to deliver it. And so I think a lot of that will depend on what the local view about physician associates is. Will people open up jobs? Because we've had you've got the training program, then you've got the sort of shadowing bit, and then you've got the when they actually start work. And I've seen people quite reluctant to open up new roles for physician associates at local level, and then that doesn't encourage people to actually go into the training program. And then it can all become very difficult. So I don't know quite what It's very difficult for government, I think, to say, right, you, Watford Hospital, you need 20 physician associates. It doesn't work that way, obviously, as you know. So I think it's a lot of that's to do with what levers different people have. That's a sort of general answer.
I think that a lot of that reluctancy has to do with, the GMC said they would regulate them, and that was already signed off, but it's just the actual process just keeps getting pushed with no real kind of reason. If they were regulated, then I think there'll be a lot less hesitation locally, like you said, because there's no clear guidelines, and sometimes the scope of what they can and can't do is certainly wishy-washy. Certainly the ones that I worked with when I was still clinical, they were being asked to do everything I was being asked to do, really and truly, but that's, but if there was an issue, it would always fall back on the supervisor. So, if they were to get regulated, they'd be more utilised, and I think currently there's thousands of them being churned out by universities, and some of them have been qualified and working in specialist units for coming up to 15 years. I know physician associates that hold registrar leaves because they've been within the same field for so long, but there's no formal training pathway, there's no regulation for them to be more properly utilised. And that's just one example. They are also present in the anesthetics world, and it's just one of those things where the government, if they were just to help with regulating these allied healthcare professionals, they would be much more, not that they're unhelpful, they're extremely helpful. My point is that they would be able to utilise their skills even more.
So I think, as Saffron said this morning, the long-term plan, we're all waiting for it. We've all contributed, we're just waiting for it. So I think the long-term plan will address some of that, but the unlocking clinical potential is sitting with the GMC, and again, they are due to rule on it. So I don't think anyone is trying to block it. It's just you actually realise that when you think things don't happen at local level, at senior level, it's even slower sometimes, but it will happen. I'm sure it will happen. But thank you for that question. Please, at the back of the room, and then we'll come forward.
Hi, my name is Harman. I'm one of the consultant cardiologists and also cross-site, clinical lead for virtual wards. So I've got a bit of an answer for that. I think the physician associates, there is a regulation coming which will start mid next year. That's what the GMC has basically said. And Royal College has already started to work to develop a Royal College for physician associates as well. So they are working on the guidelines and policies around physician associates to what they can do and what they can't do. That should be in place by mid next year, hopefully. Back to my question, sorry. The virtual wards, I've got a question around that. So we've been developing very similar to what you've done over the last few years in London Northwest. My question is around the barriers. So the barriers which we faced is the clinicians having a reluctance in referring patients to virtual wards because they are so used to the conventional ways of treating patients, and this is clearly a new way. Patients accepting that, which is slightly less in a way. I would think patients are much more up for it, but also the integration with primary care. You mentioned that you managed to have a very integrated work with primary care. Do you guys share the same system in hospital and primary care, or is there a way which you've managed to overcome this communication barrier?
So, I mean, there's obviously a clinical integration and there's the IT bit of that, okay? So I think virtual wards, my experience is virtual wards that are headquartered in the acute and led by cardiologists like yourself find it very easy to onboard patients in the acute, but struggle with onboarding patients and prevention of admission in the community. A slightly bigger problem, I think, is virtual wards that are led from within the community. There's often poor links between the community providers and the cardiologists in the hospital. The cardiologists in the hospital are reluctant to engage with the community providers and don't onboard them. So, on the other hand, prevention of admission often works better in the community. What we've tried to do is have very, very frequent meetings between the community and ourselves. There's twice weekly MDTs, and the other thing is the MDTs are attended by primary care. So initially we thought that would be the patient's own GP. That was impractical. So we have a specific GP allocated to this project who attends all the MDTs and then interacts with the patient's own GP. So that's what we've tried to do to try and the other thing is, we've just got to get that out there and talk to people as much as possible about this to try and make cardiologists realise that this is effective and safe, and other specialists. In terms of IT, we're on Cerner in the hospital and the community is on System 1. In lots of places, the community is on EMIS. So these are serious problems. If you ever attend any of the national virtual wards meetings, interoperability is always a key topic, along with prescribing. Prescribing and interoperability. And the third one is usually getting the data to flow from the patient's remote monitoring devices into the electronic record system, and it's a 120-page report just came out about a month ago on all these tech aspects. But things have improved on that. So in Cerner, you can see all the records in System 1 now. We are using System 1 in the hospital for patients, to try and bridge that. The prescribing in the community can be done on EMIS, even if you're sitting in the acute. But there really does need to be an answer to that. I totally agree with you. It can be incredibly frustrating.
Thank you very much for that question. Three at the front. So maybe start with yourself. Thank you. Young lady there. Thank you.
Hello, thank you for both of your talks, really good. My name is Fabida. I'm Medical Director at Birmingham and Solihull Mental Health Trust, a psychiatrist as well. I just wanted to ask, for both of your talks a lot about creativity, innovation, doing something different, inspiring people. However, clinicians are working in very difficult situations and there's a lot of scrutiny, there's a lot of bureaucracy, there's a lot of sensationalized when things go wrong. So the appetite for risk is quite low unless they've got the psychological safety. So how can we create that psychological safety to make the change? And in terms of digital, why don't we start at an early level, training years? Why can't we have a placement, part-time in a virtual ward? So are those things that you want to start early on, so before they become fully qualified? This is something that is part of their thinking.
So obviously the junior doctors are much better at tech than we are because, they're generational. We have launched 2 SPR roles in our virtual hospital starting this August, so we will be bringing trainees into it. I think in the mental health space, there are loads of apps coming out now to try and help people with depression and so on. And that takes us into the idea of virtual hospital for mental health issues, which I think, is a very good idea as long as the risk can be safely managed. I think a lot of people feel bringing GPs into a virtual hospital is a very good idea because they're much more comfortable looking after patients in the community than hospital doctors are, because they like having people in hospital. And I think in your question about inspiring people and so on, you know, my background in this was I was in cardiology doing cardiac MRI and echo, and I was put in a management role and then asked to take over the virtual hospital. But I can just say from personal experience, I feel 10 times more inspired about transforming healthcare than I did about 4 years ago when I was doing my routine job. So I think involving people and showing, I think the thing is people, as we heard, you know, from these previous talks, people sort of don't believe things can really be done differently, and therefore they're just, as you said, give up. Whereas, you know, I think you can inspire people to believe that things really can be done differently, especially with tech, because, you know, it's just exploding. So, you know, the appetite for risk question is we're not talking about sending people home who are about to have a cardiac arrest, though. You know, we were talking about, as I said, all the people, you know, they're not being monitored in hospital either. We're not talking about the people who are sitting in intensive care. We're talking about people sitting in a chair by a bed doing nothing. You know, those patients aren't on remote monitoring. They're just as likely to die overnight in hospital and being unmonitored as they would be at home. So the appetite for risk needs to be, you know, actually put into what the risk is in hospital, where, of course, there's hospital-associated infections, massive deconditioning of people just sitting in a chair rather than doing their own activities. So people sometimes don't factor in the risk to the patient of being in hospital.
And I think you can create psychological safety. And the risk appetite, I think, is really, really key. So through COVID, the transformation that happened, because we didn't undermine governance, there was still governance in what we did. You know, there was still all the paper trails of everything that happened. But actually we understood that we had to do things differently. And it feels like those chains and shackles are going back on. And again, I'm just going to channel Jim Mackey, because I've told him I'm going to say it everywhere. He has said, and you can write to him, he has said that if you want to do things differently and people are blocking you, you need to let us know. Because the change is in the hands, as say, of people in this room. Create the psychological safety. You know, there's already SPA time, there's clinical lead time. There are so many things that are already in the system. But once you make one change, you start to grow. But create the psychological safety. We're responsible for it, to do that. There were two other hands, and I'm going to get killed if I take another one, but let's have a go. Right, so may I ask you? Thank you very much. Oh, where are we going? Yes, you can pass that across. Thank you.
Katrina, Barts Health Outpatient Transformation. We've heard a lot about digital enablers today, but yet again, I haven't heard much about how we can change the digital deficits that we've got. So our starting positions across the country as providers are not the same, and therefore what a virtual ward will look like in Barts is going to be very different to Imperial. If I think about patient portals, again, we seem to be pushing ahead nationally with the view that all providers are at the same level, and when I'm not hearing how those deficits are going to be addressed, and I just wanted kind of some views.
So let me pick that one up. So David Sloman has just written out to all trusts with Joe Harrison, who is the National Digital Lead. And there's a great analogy, which is hospitals at the minute, they've all got roads, but some roads are tarmacked with lights and Bentleys sitting on them, and other roads are still dirt tracks. And that's where we are with digital transformation at the moment. So the gut promise from government is that patient portals will be in every single provider by the end of 24. Katrina, I still have a bit of a gulp when I say that, because I know how difficult that's going to be. There is also the conversation that everyone should have electronic patient records, and you know, Croydon, we're completely digital, and yet I go and visit and I forget that people are still paper-based, and the difficulties that brings. So I can look at results at home. I can do my, if I wanted to, my clinic from home if it was a telephone clinic. You can't do that if you're not digitally enabled. So you're absolutely right. There is a strategy. Richard Samuels is the doyen of it. There are 7 drivers. It's all set out, but we've heard it before. We need to see delivery. So I'm with you on that conversation, and I can't give you any more assurance than that. But it is on there, and it is being discussed on a regular basis. We'll have 2 more questions, and I will send you to... Oh, my God, we've got more. You're all going to kill me. So you can have 3 more questions, or you can go to tea on time. Are you happy? 4? God. Okay. Lovely. So let's start there.
Thank you.
And then we will stop.
My name's Kathy. I'm from Brighton, so I'm in education, both the medical school, nursing, etc., all the allied health professions. I suppose one of my questions really is, we've heard a lot about the virtual wards, and you touched a little bit on virtual outpatients. And certainly from my perspective, and certainly some of the work I was doing over the COVID period, it was a real need to rethink how a lot of the outpatients departments are actually functioning and working. One of my experience over COVID was that effectively they were closed. And my big success of COVID, if you can have the success of COVID, was the fact that I had this elderly gentleman who needed 4 different clinic appointments, and they were originally scheduled for 4 different days, but he would only go to the hospital once. So I managed to get him to have his scan, his vascular surgeon appointment, followed by a haematologist because he had an abnormal blood result, followed by his diabetic referral, one after the other. And the biggest barrier I had was the infrastructure, was people in the hospital thinking it could be done, that it could be done. Now, I think we need to be moving... I accept all the issues with technology and IT, but I think we've really got to be starting thinking that there has to be a better way of doing these things, and going forward, if we learn nothing from COVID, it is that we are resilient, that patients are very open to new ways of working, and we've just got to keep driving that forward. So it's less of a question and more of where are we with virtual outpatients, please?
So 2 million people. So I talked about the 100 million. 2 million people. Nick, am I going to be really, really bad if I let them go? So just tell me how many questions I can take. 2 million people use 32 million outpatients. All right, so just think. 2 million people use 32 million outpatients. If we could reduce that number by half, we solve the waiting list problem. So there is I'm putting it together now. We're hoping to launch it in 6 weeks' time, and we're going to do exactly that. I want to find that I'm talking about the missing 2 million. I can't tell at the minute who the 2 million are, so we need the data structure that does that. That's being built for me now. We then find out who the 2 million are, and I want personalised care plans for every single patient who is in there. So I need a U for every single individual. Now, the numbers are not big. There'll be about 50 to 100 per organisation. In the individual specialities, but I need to be able to go into my vascular books, and I need to know who are my 10 patients and actually work through how I can support that patient, and as you say, have 1 day of appointments rather than the cost of living crisis and make them come to hospital 10 times for things they don't need. So you're absolutely on the right track. Right, shall I take 1 more question? Yeah, I'm going to get shot otherwise. Right, 1 more question, then other questions into the break, please, if I may.
Thank you. Hi, Chris Malone, UKMD for Lucy, a remote monitoring platform plus virtual ward provider. Thank you very much for your considered lecture today. It's brilliant. What I would like to say is, my learned friend over there was talking about the differences between systems. I see multiple differences between digital maturity at different levels within systems. I understand the NHS is provider agnostic to a certain extent, but I don't see enough help coming from the centre to help these systems level up together and make purchasing decisions in an organised fashion. For example, tendering seems to be now the way to go forward for virtual wards, but I have seen even the most mature systems still struggling with what that tender even looks like, and it's quite a convoluted approach. Is there anything from the centre being done to help maybe standardise that process?
So again, that's coming through. It's a great question to finish on. So that's coming through loud and clear. So rather than individual providers, it will be, this is the digital playbook. So these are the principles that each organisation needs to have embedded to ensure their staff are supported and patients. So these are the principles, you procure against the principles, anybody can come in, because of course it depends whether you've got Cerner, you've got Epic, all the other, the solution for South West London, well, we've got 5 providers, we've all got Cerner, but we've all got different contracts with Cerner. And Cerner in itself is not the most easiest beast to move in terms of interoperability and everything else. I said that very diplomatically. That was very good. But that playbook is coming through, and this is what I'm describing. The levers that are coming through will be, this is what you should have in an organisation. These are the things that have been proven to work. You go and procure against it. But I hear absolutely everything that you say.
Just on that, though, I have to say organisations, are generating enormous costs for IT because these systems don't interact with each other. So what I would like is that, this playbook that we're hearing about, to say this is the minimum standard and these things have to talk to each other out of the box, rather than, Hospital A paying 50,000 so that data will flow from A to B, Hospital B paying 50, and it adds up and adds up. It's just, it needs to be done centrally to try and avoid huge mushrooming of costs. I totally agree.
No, absolutely. Can I say thank you very much, because you've asked questions, you've kept engaged, and it's been absolutely brilliant. Please can we have a round of applause for Niall?